بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. May the peace, blessings, and mercy of God be upon you. In the previous lecture, we studied the iron metabolism and the iron regulation. God willing, today's lecture will be about how to evaluate iron or investigations related to iron. How can I assess the level of iron in patient body? Is this patient deficient in iron? Does he have an excess iron level? Does he have enough iron but he can't use it, which is called iron restriction? How do we evaluate this? This will be clear in today's lecture, inshallah. In fact, the iron level assessment will take the form of three: assessment of iron stores, assessment of available iron supply to tissues, and evaluation of the functional iron. So, the first step is to assess iron stores. Let us recall the forms of iron storage. They were ferritin and hemosiderin. How we can evaluate the level of ferritin and hemosiderin? As for the evaluation of ferritin, it is very easy, as it is possible to evaluate its level in tissues by measuring its level in plasma, and its level in plasma is proportional to its level in tissues and expresses it correctly. If I could measure the level of ferritin in the plasma, I would have measured its level in tissues. I can also assess the iron stores by examining the tissues themselves, taking a biopsy and measuring the level of iron in them using the Prussian blue stain or iron stain. The tissues from which a sample can be taken and the percentage of iron can be measured in them include liver, bone marrow, and skin. Other methods are old methods, such as the chelation test, which is performed by giving the patient an iron chelator, followed by measurement of the amount of iron in the urine. The last method is an obsolete test, but it is written in the books, and it is to do the phlebotomy test, in which the patient donates blood until the patient begins to suffer from an iron depletion, followed by calculation of the amount of blood needed to be donated until the occurrence of iron depletion. The larger the amount of blood needed to be donated for the occurrence of iron depletion, the larger the iron store. As for the evaluation of tissue supply with iron, I want to know if the iron that reaches the tissues is enough to support erythropoiesis or not. How is it evaluated? Very easy, by measuring the serum iron. What is the serum iron? It is the iron that circulates. It is carried on the transferrin protein. What do you guess? Also, if we measure this transferrin protein itself. Transferrin can be difficult to measure, but we can replace its measurement with an easier and cheaper test called TIBC, or total iron binding capacity. Also, what do you guess if we measured that percentage of transferrin saturation with iron? It is called the transferrin saturation. Also, we can measure the soluble transferrin receptor. If we remember, transferrin had two types of receptors, transferrin receptor 1 and 2. Transferrin receptor 1 had two forms, membrane-bound and soluble form. We mentioned earlier that the soluble form is formed by truncation of the membrane-bound form from the surface of the cell, and therefore it is precisely proportional to the level of the transferrin receptor 1 on the surface of cells. Another way to measure the iron supply to tissues is to measure the free protoporphyrin present in red cells. I know that red cells consist mainly of hemoglobin, which consists of heme and globin. And the heme consists of protoporphyrin and iron. So, what do you guess if we measure the free protoporphyrin so that it gives us an idea of the level of iron in red cells? What do you guess about the measurement of ferritin inside the red cells? There is another way. It is to measure the percentage of hypochromic red cells, as they are cells in which the iron level is deficient and the percentage expresses the level of iron supply to tissues. And what else? There is also the reticulocyte hemoglobin content test. It is a measure of the amount of hemoglobin present in the reticulocytes. These all tests measure the iron supply to tissues. As for the third form of iron assessment, which is the assessment of functional iron, the functional iron is the actually used iron, which is mainly used as the hemoglobin. It is easy to measure the hemoglobin concentration and the MCV and MCH of RBCs. Now we will begin to talk about each form in details. Let us start by talking about evaluating iron stores. As we said, the easiest assessment of iron stores is to measure the level of the protein known as ferritin in the plasma. It is known as serum ferritin. We have mentioned that the level of ferritin in the plasma is an accurate expression of the level of ferritin in the tissue. If we measured the serum ferritin, it was as if we measured the ferritin and thus the iron stores in tissues. But the truth is that serum ferritin is a test that has some defects, as ferritin is also affected by inflammation in the body, as it is an acute phase protein, meaning that the inflammation leads to an increase in the level of ferritin in plasma and in macrophages. We mentioned that in the previous lecture, when we mentioned that during inflammation, what's called iron restriction occurs as a result of the high hepcidin. The high hepcidin sequestrates iron in the form of ferritin in cells, which constitute an obstacle to the use of serum ferritin as a measure of iron stores. Since in case of inflammation, the iron stores are very high, but at the same time, it is not available for erythropoiesis. Accordingly, not every patient with high ferritin level in the plasma suffers from iron overload. He may suffer from inflammation that is accompanied by iron restriction. Therefore, we can say that the serum ferritin test has a very high value if the ferritin level is low, as there is no other reason for that. But if the ferritin level is high, this rise may be due to iron overload or due to inflammation. What does this mean? This means that the low ferritin level doesn't have a differential diagnosis, but its high level has reasons other than the iron overload, so it has a differential diagnosis. The second way to measure iron stores is to take a tissue biopsy and measure the amount of iron in it. So, what are the tissues from which it is possible to take a biopsy and measure the amount of iron in it? The most famous of them is the bone marrow, from which a sample is taken and stained with an iron stain to measure the amount of iron in it. We will have a pause here to explain the iron stain in the bone marrow. The second of these tissues is the liver and skin, but this is an old test that was used in the past, as it is an invasive procedure and the preparation of the biopsy takes a long time and also it is difficult. This test has been replaced by the MRI or magnetic resonance imaging on the liver, which performs these tasks with complete success. We will now return again to the iron stain in the bone marrow. What is the iron stain? This is a test in which we add potassium ferricyanide to the tissue to be stained. Potassium ferrocyanide in the presence of hemosiderin is converted to ferrocyanide, which is blue in color, and thus detects the presence of hemosiderin. This is the base for the iron stain test. For the bone marrow, what would you expect about hemosiderin? Bone marrow is one of the reticuloendothelial system which contains macrophages that contain hemosiderin. And for the normoblast, it is normal to find hemosiderin granules in it. Yes, it is normal to find hemosiderin granules within 30 to 40% of the normoblast in the bone marrow, provided that these granules are few, small, and randomly distributed in the cytoplasm. These normoblasts are called sideroblasts. So it is expected that hemosiderin will be present in the bone marrow within the macrophages and 30 to 40% of the normoblasts called sideroblasts, provided that these granules are few, small, and randomly distributed in the cytoplasm. So, when commenting on the iron stain, it must be commented on the status of iron in macrophages, the number of sideroblasts, the number of hemosiderin granules inside them, the size of the granules, and their distribution within the cell. Then, we will give examples for this. First, in cases of iron deficiency, what do you expect to find in iron stain of bone marrow in these patients, where iron will be? The truth is that this patient suffers from iron deficiency, so it is not reasonable that he stores iron in the form of hemosiderin. Therefore, I don't expect hemosiderin to be present in abundance. So, I will not find hemosiderin in macrophages or find a few hemosiderin granules in the macrophages. And for normoblasts, I expect a decrease in the percentage of sideroblasts, a decrease in the number of hemosiderin granules, and the smaller size of the granules. And I expect also that these granules are randomly distributed within the cytoplasm. The opposite is true in patients with iron overload. These patients store excess iron in the form of hemosiderin. Therefore, I expect hemosiderin to be present in abundance. So, I will find hemosiderin in the macrophages in excess. And for normoblasts, I expect an increase in the number or percentage of sideroblasts more than 40%, and an increase in the number of hemosiderin granules. The size of these granules will be also larger, but they are still randomly distributed within the cytoplasm. For patients with sideroblastic anemia, we will now briefly mention the iron stain in this disease, till the lesson is explained in details. These patients have a problem in the production of protoporphyrin, but they don't have a problem with iron. We know very well that the mitochondria is the site of iron union with protoporphyrin to form the heme. In the absence of protoporphyrin, iron is deposited in the mitochondria. It is expected in these patients that there is an increase in the iron, whether in the macrophage or in the normoblast. So, we will find that the number of sideroblasts or the percentage of sideroblasts is in excess. We also will find an increase in the number of hemosiderin granules and an increase in the size of these granules. But here, the granules will not be randomly distributed inside the cytoplasm, but will be deposited in the mitochondria whose normal location is around the nucleus. So we will find that they are deposited in the form of circle around the nucleus. And therefore these sideroblasts are called ring sideroblasts. And this type of anemia is called sideroblastic anemia. For patients with anemia of chronic disorders or anemia of chronic inflammation, what should I expect to find in the iron stain in these patients? In these patients, iron is present as it is not efficient. Thus, in this patient, there is what is called iron restriction, meaning that the iron in this patient is trapped inside the macrophages and is not available to reach normoblasts to synthesize hemoglobin. Therefore, I expect in these patients the presence of hemosiderin in abundance within the macrophages. And for normoblasts, I expect a decrease in the number or percentage of sideroblasts, a decrease in the number of hemosiderin granules, and the smaller size of these granules. I expect also that these granules are randomly distributed within the cytoplasm. Now we have known the form of iron stain in various diseases. As for the rest of tests that evaluate the iron stores, there is a so-called chelation test, in which the patient is given an iron chelator, and then the amount of iron in the urine is measured in 24 hours. The patient is given an intramuscular injection of desferrioxamine, 0.5 gram. Then the amount of iron in the urine in 24 hours is measured. It is normal for this amount to be less than 2 mg per day. If more iron than this is found in urine, this means that there is an iron overload. The next test is known as a phlebotomy test, and it is an old test that is not currently used. In it, the patient donates a bag of blood once a week, which contains 450 ml of blood, and the amount of iron restricted in the diet to be less than 3 mg per day. The number of blood bags needed for donation is calculated until the patient has an iron depletion. Normally, if a person has a hemoglobin concentration of 13.5 gram per deciliter, then when he donates 450 ml of blood, he loses 200 milligram of iron. The amount of iron needed to be lost to develop the iron depletion is calculated. Of course, a very strange test, and therefore it is not used now. The second step is evaluating the iron supply to tissues. This is done by measuring the level of iron in the blood. Also by measuring the amount of the iron transporter protein, the transferrin. And because measuring transferrin is expensive and is not available in all laboratories, it is possible to replace its measurement by measuring a number of places available for iron in this protein, whether these places are loaded with iron or not. This test is known as the total iron binding capacity, or TIBC. If we assume, for example, that there is a group of 5 buses, each bus is sufficient for 8 passengers, then the places available for passengers in this group will be 40 places, whether they are occupied with passengers or not. Meaning that the load of this group is 40 passengers. Or we can say that the total capacity of this group is 40 passengers. The number of the loaded passengers in this group may be 2 only, or it may be filled with more than 20 passengers. It is normal for only 1/3 of the capacity of the transferrin to be occupied by iron, and the remaining 2/3 to be unoccupied. This means that this group must normally carry about 13 passengers and have about 27 places that are not occupied, meaning that the unbounded capacity of this group is 27. Let us guess what happens in serum iron, total iron binding capacity or TIBC, unbound iron binding capacity or UIBC, and transferrin saturation in various diseases. First, the UIPC or unbound iron binding capacity refers to the empty places in the transferrin that are not occupied by iron. In this picture, the iron is presented by the red column. The UIPC is presented by the light blue column, and the TIPC is the sum of the two or the length of the whole column. Normally, it is normal for iron to occupy 33% or the third of transferrin places, which is measured under the name of serum iron. Don't forget that we have a fixed rule in medicine, which is that any protein carrier of any substance is inversely proportional to the proportion of this substance. This is the logical rule, because when the substance is needed by the body, the production of the protein that carries it increases, so that any amount of this substance is immediately utilized, even if it is a very small amount. Inversely, when the substance increases, the synthesis of its carrier protein decreases, as there is no urgent need for its rapid transport. With regard to iron, the amount of transferrin present in the body is inversely proportional to the amount of iron. The more iron deficiency, the greater the transferrin, and vice versa. Now, let us see what happens in cases of iron overload. If we apply this to the example of buses, we will find that the actual count of passengers increases to about 20 passengers, which was normally 13 passengers. So, it is normal for the number of available places in the buses to decrease. We will find that the normal load of the 40 passengers decreases to about 30 passengers, for example. Consequently, the places that are not occupied by passengers decreases a lot. And now there are only 10 places out of the normal 27 places. Let us return to cases of iron overload. In these cases, of course, iron increase, which is expressed by the serum iron, the red column. And the transferrin or TIBC decreases, the whole column, according to the above mentioned rule. As a result, the places that are not occupied by iron or UIBC, the light blue column, are reduced. Don't forget that these patients have a very large store of ferritin, meaning that the serum ferritin increases. Let us now guess what happens in cases of iron deficiency. If we apply this to the example of buses, we will find that in this case, there is a decrease in the count of passengers. So, it is expected for the number of available places in buses to increase. So, we will find that the load of the 40 passengers increases to 60 passengers, for example. And what about actual count of passengers, which was normally 13? In this case, the actual count of passengers decreased to about 10 passengers, meaning that the seats are empty. Thus, the places not occupied by passengers have increased a lot and are now 50 places out of the normal 27 places. Let us return to cases of iron deficiency. In these cases, of course, iron decreases, which is expressed by the serum iron or the red column. And then the transferrin or TIBC increases, the whole column, according to the above mentioned rule. As the result, the places not occupied by iron or UIBC, the light blue column, increase. Don't forget that this patient has a very small store of ferritin, meaning that the serum ferritin decreases. Now, what about patients with chronic inflammation? If we apply this to the example of buses, we will find that in this case there is a thief or an invader trying to kidnap passengers or iron to help in its growth. So the body performs a defensive trick, which is the trapment of iron or passengers or inhibition of their transport through decreasing the rate of production of buses or transferrin, which transport them, depriving these thieves or aggressors from iron. Therefore, transferrin is considered one of the negative acute phase protein, meaning that it is decreased in cases of inflammation. We will find that the number of available places in buses decrease and that the normal load of 40 passengers decrease to 30 passengers, for example, meaning that the TIPC, the whole column, decreases. And what about the actual count of passengers, which was normally 13? In this case, the actual count of passengers decreases to about 10 passengers, meaning that the serum iron or the red column decreases. Don't forget that this patient have a very large store of ferritin, as ferritin is one of the positive acute phase protein, meaning that it increases in cases of inflammation. Let us finalize this part by explaining what is called transferrin saturation, which is the extent of transferrin saturation with iron. Is it evaluated with a test as well? No, it is calculated by an equation that includes dividing the serum iron by the TIBC. Let us return to this picture. It is calculated by dividing the length of the red column by the length of the whole column. But in reality, things are not that simple. The patient may suffer from a combination of these disorders, like a chronic inflammation patient, for example, who also has an iron deficiency. We will find that in this patient the interpretation of iron profile is difficult because he is exposed to more than one effector, not just one. In these cases, we need more advanced and more specific tests to interpret their iron profile. It is possible to use the measurement of so-called soluble transferrin receptors. Let us remember that transferrin has two types of receptors, namely transferrin receptor 1 and 2. And the transferrin receptor 1 had two forms, a membrane-bound form and a soluble form, which is formed by the truncation of the membrane-bound form and circulates in the plasma. The level of the soluble transferrin receptor in plasma is directly proportional and accurately expresses the number of transferrin receptor 1 on the surface of cells. The rule also says that the number of receptors of any substance is inversely proportional to the level of this substance. The lower the level of the substance, the greater the number of its receptors, and vice versa. There's also a logical rule because when the substance is lacking, the cells urgently need it. So the body produces a greater number of receptors so that it can benefit from any amount, even a small amount of this substance. And the opposite occurs in cases of increasing the level of this substance. The body, in these cases, doesn't need to produce this receptor urgently. So the production of these receptors decreases. Let us return to the lecture of iron assessment and apply this rule to the transferrin receptor. We will find that it increases in cases of iron deficiency on the surface of the cells, and therefore the level of the soluble transferrin receptors in the plasma increases according to the increase in their number on the surface of the cells. It was found that this test can differentiate cases of iron deficiency from cases of anemia of chronic disorder, as it increases in cases of iron deficiency and decreases in cases of chronic disorders. In fact, this test is also affected by the rate of erythropoiesis. The higher the rate of erythropoiesis, the cells need a greater amount of iron, and therefore the protection of these receptors increases. Therefore, the production of these receptors decreases in cases of chronic disorders. In order to make this test more specific, we have introduced another factor, which is the log of ferritin. The inner ratio is calculated through dividing the soluble transferrin receptor by the log of ferritin. It was found that this ratio has a higher sensitivity and specificity in differentiating between iron deficiency and chronic disorders. Also, one of the methods for evaluating the iron supply to tissues is a group of tests related to RBCs, such as the measuring of the free protoporphyrin inside the RBCs, which will be inversely proportional to the amount of iron inside the RBCs. So that when the amount of iron decreases, the protoporphyrin doesn't find anything to unite with, so it remains free inside the RBCs. Likewise, the red cell ferritin, which is directly proportional to the amount of iron that reaches the RBCs. There is also a test known as the percentage of hypochromic red cells, in which the percentage of RBCs that lack iron is measured, a calculation which needs an automated instrument. In this, if this percentage increases, it means a lack of iron that reaches the RBCs. It is also possible to measure the reticulocyte hemoglobin content. However, these tests have some drawbacks. They assess iron at the time of synthesis of these RBCs, but are not a general assessment of iron. Also, one of the disadvantages of these tests is that they are affected by any effect that affect the binding of iron to protoporphyrin. For example, in cases of sideroblastic anemia, these patients suffer from a problem in the production of protoporphyrin, affecting the results of these tests. The last point in the evaluation of iron is the evaluation of functional iron, which is mostly found in the form of hemoglobin. Therefore, this part of the iron is evaluating by measuring the concentration of hemoglobin and measuring the MCV and the MCH or of the RBCs. Thus, we are now able to assess iron in its various forms in the human body. And after that, I hope that this lecture will reach the greatest number of hematology students, and that they will benefit from it as much as possible. God bless you. Assalamu alaikum wa rahmatullahi wa barakatuh.